Welcome to this short presentation, which has been made at the request of maternity units who are in the process of convincing their trust boards and senior management as to why they should move from NICE guidelines on CTG interpretation to physiological interpretation of CTGs. I want us to go back to our fetal life. And once the labor contraction started, as human fetuses, we were exposed to stress. And that's because our, our fetal head got squeezed within the maternal bony pelvis. The umbilical cord got squeezed 3 to 4 times in 10 minutes for 1 minute each. And the placental blood supply got affected because those spiral arterioles had to traverse the myometrium to supply our placental venous sinuses. So each time our mums contracted, all those placental venous sinuses also got squeezed. And my mum did this for 8 to 10 hours. And therefore, as a human fetus, in response to ongoing stress of uterine contractions, I did show a stress response. And this is similar to adults, you and I going to the gym. And if you go faster and faster on the treadmill, you will find that you become tachycardic and tachypneic as a result of the hypoxic stress. And if you ask yourself, how long does it take for the human fetus who is exposed to this hypoxic stress to have hypoxic-ischemic encephalopathy or brain damage as a result of intrapartum hypoxia? We will all say, based on our midwifery school and medical school knowledge, that it depends on several factors. If you are small, if you are growth restricted, you simply don't have reserves to go for 90 minutes or 2 hours. If your placenta is not functioning well, if there's poor placentation, if there's poor gas exchange, you cannot go on for a long time. If your mom is unwell, COVID-19, sepsis, diabetic ketoacidosis, her environment is going to be detrimental for your existence and the stressful process of labor. Then oxygen demand is very important. If you're large, if you are a baby of a diabetic mom and you're macrosomic, your metabolic demands are high, your oxygen requirement is high, and you cannot go through the same distance with the same stress. The intensity of hypoxic stress is also very important. So if your obstetrician starts your mom on oxytocin, your intensity of stress has increased. In the same way, in second stage of labor, once your mom has started active pushing, your intensity of stress has increased, and therefore you cannot go for the same duration of time to have brain injury. And coexisting problems, fetal problems, are extremely important. It's similar to if you and I have bacterial sepsis or infection or flu, going to the gym and trying to do the same exercise that we have been doing for the last 2 weeks. Infection and inflammation predisposes us to hypoxic injury. So the NICE guidelines simply have a table grouping a set of features, and if they have 50% of the contraction for 30 minutes, they call it suspicious. And if these ugly decelerations go for 50% of the contraction for 30 minutes, they are called pathological. In all these babies, in all these different circumstances, the guideline sticker is the same. And arbitrarily, by grouping features together, they classify the CTGs into normal, suspicious, pathological. Whereas the physiological CTG guideline is about determining the fetal compensatory responses to ongoing stress of labor, to differentiate features of compensation on the CTG trace from decompensation, and to determine the type of intrapartum hypoxia that is observed on the CTG trace. By asking the question in labor, how is this fetus, not any fetus? So let's go and look at why we need to move from NICE CTG guidelines to physiological CTG guidelines. And before I go through this, I like to tell you that I follow several NICE guidelines in my clinical practice, as long as they are evidence based, they are objective, and they are logical, and is based on current best evidence. So I do declare that conflict of interest, that I'm a very strong NICE guideline follower. But I'm talking about NICE CTG guideline. So let's go and look at where is this evidence for 30%, 50%, 30 minutes, etc. came from. So all these numbers on the guideline sticker, you can see how many different numbers our national guidelines have put in the CTG sticker. And if you are a junior doctor or midwife at 2 in the morning trying to circle these stickers in trying to determine what should I do, you must have wondered, where, where did these numbers come from? So let's go and look at NICE guideline itself. And to be fair by the NICE guideline group, they have clearly and explicitly stated this in the guideline as to why they say what they say. So they have accepted that there was no evidence for any of these numbers. In fact, the guideline development group had initially argued. There were approximately 5 obstetricians in the guideline group. The group consisted of a larger group of anesthetists, the patient representatives, midwives, etc. But the obstetricians who were experts in CTGs, because it is not a low risk issue, it's a high risk labor, there were only about 5. And they initially argued what numbers to put, and then they reached a consensus according to the guideline, and they simply they just felt that for severe variable decelerations, and mind you, no other international guidelines classify decelerations as mild variable and severe variable except the NICE CTG guideline. And they say, based on what they felt, for severe variable decelerations, they just arbitrarily chose 30 minutes. For mild variable decelerations, they arbitrarily chose that it should be 90 minutes. So you could see the numbers that the stickers have, the numbers that are being applied on UK babies as we sit here, they are not based on scientific evidence. They are based on a group of obstetricians who simply, as they have honestly stated, plug these numbers just because they felt it. Again, the other problem we have is that variable decelerations are due to cord compression and late decelerations are due to uteroplacental insufficiency. But the NICE guideline put both these in the same group as abnormal features and gave them the same duration of time. And if you ask why, again, they say there was no evidence, that the group simply felt it, empirically said 30 minutes. And this is again one of the most, in my opinion, dangerous aspect of NICE guidelines, where they artificially increase the threshold for abnormal CTG from 160, which was based on research evidence and has been used by American guidelines from 1979, FIGO guideline from 1987, and all international guidelines. Whereas in the UK, for some reason, the national guidelines artificially increase the threshold for abnormal heart rate from 160 to 180. And you can see what the problem is. If you go to a medical ward and if you artificially increase the upper limit of adult heart rate from 90 to 130, we are going to have a group of humans in medical wards with sepsis or hemorrhage or other medical problems having a baseline heart rate of 120, but will be considered as normal or suspicious because they have artificially increased the baseline heart rate of abnormality. And if you ask yourself why, again, the group says they simply plucked it from thin air empirically. And there was no evidence to confirm that. But you can see the problems it's going to have for babies. If you're a growth restricted baby with a small adrenal gland, you will never be able to go above 180 to become abnormal in the UK. Whereas in Spain, in France, you will become abnormal. But in the UK, you cannot become abnormal because they have artificially increased your baseline heart rate threshold without any evidence. And it is totally dangerous. If you're a baby with chorioamnionitis, each degree rise in the baseline increases the heart rate, temperature increases the heart rate by 10%. So if you're coming at term with a baseline of 120, 10% of 120 is 12 beats, so you go to 132. Even when you're running at 40, 41 degrees, you may not go beyond 160. But then in the UK, the guidelines fail you because you will never become abnormal. And because if you increase your temperature by 5 degrees, you'll be cooked inside and you'll be dead due to hypopyrexia. So you can see the problems the NICE guidelines have. All these numbers that have been stated in the guideline are not based on any scientific evidence. They are based on personal opinion, and they have said, we felt it, and no robust scientific evidence for this. And by increasing the upper limit very unfairly, in my opinion, because that's going to cause damage to so many babies who are unable to increase the heart rate to 180. And none of the international guidelines have done that. In fact, if you look at who is paying the price for it, is babies with chorioamnionitis, because that is sepsis. And in sepsis, each degree rise in temperature will only increase your heart rate by 10%. And therefore, you may not be able to go to 180, 190. And fetal growth restriction, you simply don't have enough reserves. And RUPID, babies with relative uteroplacental insufficiency, like large diabetic baby, their placenta is having a relative problem, and you will not be able to increase the heart rate. And if you look at chorioamnionitis, it has been clearly shown that the average increase in the heart rate is about 25 beats per minute. And about 43% of babies did not go beyond 160 beats per minute. And therefore, all these babies will be failed by NICE guidelines. Because by NICE guidelines, your heart rate has to be 161 to 180 to become suspicious. But if you have infection, you don't increase the heart rate that much because it's not hypoxia, it's sepsis. And if you look at FIGO guidelines, I was privileged to be the Royal College representative to represent the UK in the 3-member guideline group. And we revised the guideline with 50 experts from 37 countries. And one of the first things we did for FIGO guideline in the pathological CTG, we did not have an upper limit. We wanted to treat each baby as his or her own control. Every baby is precious. They are individuals. So if the baby's heart rate goes from 140, 20 to 150, that baby has increased the heart rate by 30 beats. That's 20% of their cardiac output, and that is abnormal for them. If you look at International Physiological CTG Guidelines, which was produced by 34 experts from 14 countries in 2018, where we have even taken away the upper limit, and we have put it 10% rise compared to previous recording. And that is individualization of care. Whereas NICE CTG guideline, not only they didn't, they should have taken away the upper limit, but actually they increased the upper limit to 180, which means all these babies will be missed and they have poor outcomes. And there's evidence for it. If you look at NHS resolution report, it is not only the problems of fetal monitoring that's a problem. That's just the tip of the iceberg. But 15.6% of babies who are going for brain cooling, they are not having hypoxia predominantly. They're having infection. And you can ask yourself, why are they having a problem? Because in our national guideline, these babies have no chance to be picked up because the baseline has been increased. And the guideline says, even if the baseline goes between 161 to 180, it is just suspicious, and offer fluids to the mother. The baby is having a problem, sepsis, and the mama who has got 6 liters, she's struggling with fluid overload of pregnancy. There's a 50% expansion of plasma volume. And according to this guideline, she's to be offered fluids. And are you surprised then that the NHS resolution report has highlighted by giving too much of fluid. Not only we are having maternal hyponatremia, increasing the risk to the mother of ITU admission, and we are also increasing the risk of neonatal admissions in the UK because of blind adherence to guidelines. And the guidelines just change those parameters without any scientific evidence, but by the feeling of few around the guideline table. And when you look at studies in chorioamnionitis, it's a fetal disease, not a mother's disease. We cannot be looking for temperature and pulse in the mother because what we look for in chorioamnionitis is evidence of neuroinflammation on the CTG. And only 73% of women at the end of severe infection, after the brain baby shows you evidence of neuroinflammation, would have pyrexia, which means 30% we would miss them. And the NICE CTG guidelines do not talk about features of neuroinflammation on the CTG, such as the zigzag pattern in their guideline box. And they have artificially increased the baseline heart rate to 180. So all these babies are being missed in the UK because the guidelines simply would not pick them up. Similar situation in COVID-19. In COVID-19, most of the problems you see on the CTG trace, the pathological CTGs, are not due to the mother's baby's problem. They are due to mother's problem reducing the oxygen supply to the baby. And therefore useless going and doing cesarean section for pathological CTGs according to NICE guidelines when the problem is in the mother's compartment, and we need to be correcting the mother's compartment to make the babies better. So you can see how it's not only the babies are being missed, that these guidelines with all these arbitrary parameters, which are plucked out with no evidence, are also causing harm to the women in terms of unnecessary operative interventions. So the next issue is, okay, we have a national guideline, NICE CTG guideline. Does it improve perinatal outcomes? So we need to go back to what happened in the UK. This is the RCOG CTG guideline. And most of us like it because it is simple. It gave obstetricians and midwives the ability to think outside the box because it is simple with less numbers. But the problem is, in human physiology, we cannot be just putting a few numbers and letters and then grouping them into normal, suspicious, pathological. It doesn't work. No other doctor does it. Our general practitioners, they don't do it. No other doctor in any other ward will just group a series of features and call it normal, suspicious, pathological, and give the same treatment to every person with a suspicious or pathological CTG. But so we should not be surprised then that the chief medical officer if in the UK in 2007 published this report highlighting the mistakes we are making. These were these babies, sadly, they are intrapartum related deaths, and 500 of them in a year. And then what did we do? Instead of improving ourselves, we confused our junior midwives and doctors and senior midwives and senior doctors, including the consultants, with more numbers in the guideline box. And all these numbers are not scientifically based. They are not evidence-based. They are just personal feeling of a few people around the table. And what happened was, when you introduce it in a large scale for the whole of the UK, a tool which is not scientific, we should not be surprised that the NHS Litigation Authority, the precursor of the NHS resolution, who paid out the money when we make mistakes, they said in 2009 that when they looked at successful stillbirth claims, 100 of them, 34 of them were due to CTG misinterpretation. And that's the time the public started to wake up to say that obstetricians and midwives may not know what they are doing with the CTG machine because babies were not only getting brain damage, they are also having stillbirths. And then the Each Baby Counts report came and confirmed our suspicion that we were having for a long time, that we are having problems with intrapartum fetal monitoring. Out of 921 babies who died in 1 year, you can see 655 babies They didn't have mild or moderate brain injury, but they had severe brain injuries. Really, really damaged. And then we started confusing good doctors and good midwives with bad guidelines. In 2017, when the guidelines were revised to make it even more complicated and confusing, it's not surprising that the Each Baby Counts report 1 year later showed that the number of babies had increased from 921 to 1,123 babies in a year. And not only that, the number of babies who had got severe brain damage, they have also increased from 655 to 854 1 year after. And for the first time, we have been told that guess what? Two-thirds of them, more than two-thirds, 71%, a different care may have been given rise to different outcome. In other words, in layman's language, without the flowery bit of it, is that they would have had a better outcome. They would have, if we had done something different, they wouldn't have ended up on a wheelchair. They wouldn't have died during labor. That's what it means. But we know why, because all these numbers are not based on scientific evidence. And then this is last year, we increased from 1,123 to 1,130 and 850 babies on a wheelchair. And we should not be surprised that different care might have made a difference to a different outcome in 72% of the cases looked at. So you can see the reason why this is not working. And this is the latest report this year. And again, we have gone from 1,130 to 1,145. For those who love p-values, they might say it's not statistically significant. But those who are humans, human doctors and human midwives, that means there are 13 more families and 13 more babies, and that is one a month extra. That's what it means. Let's not look for p-values when our own guideline is not scientific, is not based on scientific robust evidence. So let's not say just because it increased from 1,130 to 1,145, it is not statistically significant. Let's not say that. And let's ask those women and families to have to look for 9 extra babies. The severe brain damage went from 850 to 859. Let's ask those families whether those 9 extra babies, they consider it as statistically significant or not. They would say from a human cost point of view, they are very, very significant. And the latest report has said that we have gone up from 71% to 74%, that a different care would have given rise to different outcome. And this is the commentary I wrote for the Journal of Patient Safety and Risk Management after the previous Each Baby Counts report. This was in 2019. And I'm sure everyone would agree that as healthcare professionals, we are privileged to assist a woman in bringing a new life into this world. All of us have a duty to practice evidence-based medicine. And I think that is not controversial. If I go with cancer, if I go with heart attack to a doctor, I expect that doctor and nurse to practice evidence-based medicine, to treat me according to the current best evidence, not the evidence that is available, but that was available 40 years ago. I'm sure this is not controversial either. If it is my baby, I would want every baby to be treated as an individual, not as a box, another tick box in another sticker. I'm sure this is not controversial as well, that we owe it to our patients to understand fetal physiological knowledge and responses. There's nothing controversial about it. So what is this physiological interpretation of CTG? If NICE guidelines, which are based on personal opinion and not robust scientific evidence, is not working, what is the alternative? So the principles of physiological interpretation of CTG boils down to individualization of care. It's all about asking one question first when we see a baby. Is this fetus fit to undertake the journey of labor? And then, is this fetus compensating for ongoing hypoxic or mechanical stress? In the gym, we are exposed to stress. When we run, when we jog, when we swim, we are exposed to hypoxic stress. But are we compensating to the stress? And it's all about understanding the responses, fetal responses, different types of hypoxia, non hypoxic causes, and incorporating the wider picture so that we don't manage every baby with the same sticker. We individualize care for each baby. So at the beginning, we need to make sure that the central organs are well oxygenated. The heart, the autonomic nervous system, the somatic nervous system, are they well oxygenated at the beginning of labor? Do I have any problems with the placenta? And how is this person I'm looking at room 2 different to another baby in room 5? What is the baggage that baby is carrying? So we don't treat all the babies together, but we ask the question first, is this fetus fit to undertake the journey of labor? And if the answer is no, then it is a semi-elective cesarean section, and we should not be putting that baby through labor. Because if you put that baby through labor, just like if I go with a pre-existing heart disease to the gym, and if you push me on the treadmill, I will collapse, and that's what they do too. And once we understand the pre-existing injury, then the physiological interpretation of CTG involves understanding the features we see on the CTG. So we don't classify the CTG into normal, suspicious, pathological, but we constantly ask the question, how is this fetus based on our knowledge of physiological responses of a human fetus? But that's not enough. We need to understand the different type of hypoxia, and then we need to put everything together in the wider clinical picture. So for example, if the mom is not progressing well, if there's meconium, if there's temperature, etc. And we talk about mothers. These are the wider picture that can affect the baby. It's not only the mother's compartment, infection in the mother's compartment, but also fetal compartment is very, very important. So physiological interpretation of CTG is all about understanding the fetal responses to stress. It's about treating each baby as a person, understanding that changes can happen in the same baby, like pre-existing hypoxia, during labor, chorioamnionitis, and catecholamine surge. They can all increase the heart rate. So we cannot have an arbitrary number 110 to 160 or 110 to 160, 180 as normal. You might say, is there scientific evidence that it works? Well, when we looked, we wanted to find out not only the use of physiology to interpret the CTG trace, but we wanted to ask a question, is it possible that when we are managing babies in labor, by the understanding of fetal physiology, can we predict the next stage? And we were able to show that it's not only possible to determine the fetal response to hypoxic stress and correlate them with perinatal outcomes at the time of birth, we are able to predict what the baby is going to show next on the CTG based on the knowledge of fetal physiology. So, who produced these guidelines? So there were 34 experts from 14 countries who are into physiological interpretation of CTG. And we were very privileged to have my mentor, Professor Sabaratnam Kumaran, who has published a lot of scientific information and evidence on CTG interpretation. And that is freely available for download. And this guideline does not have normal, suspicious, pathological, but it classifies CTGs based on the type of hypoxia. And not only that, it gives what to do in terms of in different types of hypoxia. And there are different types of hypoxia human babies are exposed to at different times in labor. And the Physiological CTG Interpretation Guideline recommends two tools to be used. First, at the beginning of labor, to find out whether this baby that we are looking after, not any baby, this baby is fit to undertake the journey of labor. The second tool is each time when you look at the CTG, you can see there are no numbers to circle because we have very intelligent midwives and doctors in the UK. All they need is information. They have intelligence. So they don't need to circle 110 to 160. You can see it's a rise in the baseline over 10%, etc., to look for features of neuroinflammation, to not to miss those babies with hypoxia, and not to miss the babies with infection. And you might ask, well, Edwin, does it really work? So when I was appointed as a labor ward lead consultant at St. George's Hospital in London in 2005, I was there from 2005 to 2020. I was appointed on the back of an HIE review, hypoxic-ischemic encephalopathy review, because there were concerns that St. George's HIE rate was very high at that time. So when we introduced physiological interpretation of CTG, you can see I left in February 2020. So until that time, our intrapartum emergency cesarean section was 6% to 8%. And the total cesarean section, despite of us running a regional service, referral service of placenta accreta, was 22 to 27%. And you can see once we trained all the staff on physiological interpretation of CTG, our metabolic acidosis rate at term fell quite significantly. When I joined, the publication said it was 2.8%. And now when I left, it was 0.6%. So you might say it must be to do with something to do with tooting water, because the moment the obstetricians at St. George's Hospital learned about physiology, they stopped cutting the baby's skin for fetal blood sampling. They reduced the amount of intrapartum cesarean section by 30% and reduced the amount of hypoxic ischemic encephalopathy by 50%. But everywhere doctors are clever, midwives are clever. These are the hospitals in the UK and abroad where I have done CTG masterclasses based on physiology. You can see there's a consistent, the first thing the doctors do is to stop cutting the baby's skin, because they know that that is useless. They understand physiology. Once you understand physiology, you don't have to waste time and cover the ignorance by cutting someone else's skin to find out whether the brain is acidotic. But you can see there's a consistent reduction in fetal hypoxic ischemic encephalopathy and cesarean section. And our team got a national award in 2016 for low total cesarean section, low intrapartum cesarean section. And this is what I'm very proud of, half the national average of cerebral palsy, HIE. And you might say we need long-term data. This is a hospital in Carmarthen in Wales. You can see their HI rate was about 13 cases. And this is not only the physiological training through master classes. What you need is a local leadership. You need to have a midwife and a doctor. So in Carmarthen, you have Shankar and a group of midwives and doctors who are focused on improving care. They are focused on individualization of care, because they recognize that the NICE sticker doesn't work. And when you do that, it's zero. So you can't stop all HIEs. You will have HIEs due to antenatal problems and antenatal damage. All we can do is to avoid or make hypoxic ischemic encephalopathy due to intrapartum hypoxic insult to zero. We should aim to make HIE due to CTG misinterpretation to zero. That's what we can do. And they have done it really well for the last 4 years. And you might say, does it come at an increased cost of an emergency section going up? Well, because pathological CTGs, the false positive rate is over 90%. You not only make it better for babies by reducing HIE, you also make it better for mums. You might say we want long-term evidence, so we looked at 11-year data, 52,000 births, and our HI rate was 0.3 per thousand, which is one-fifth the national average of in the UK. And our intrapartum fetal monitoring team again got another national award in 2017 for excellent perinatal outcomes. And this hospital in Greenwich, you can see once everyone is trained, again, there's Marike and the team who are focused on reducing brain damage and meconium aspiration syndrome. And there was a significant reduction in both HIE and meconium aspiration syndrome rate once they understood physiology and applied to daily life. This is South Warwickshire. Again, you need local leadership. Suganya and the team there, she's a labor ward lead, and she is pushing Physiological Interpretation of CTG, you can see the total intrapartum cesarean section rate to fetal compromise went from 30% of all cesarean section to about 5%. And this is why I do the master classes and training on physiology. And you can see once you make doctors and midwives in the UK, who are very clever people, once they understand the physiological responses, you can really make a difference to cerebral palsy. So you can see by using a sticker with 50%, 30%, 90% contractions, which are based on personal opinion, and missing the baby. Once you put the baby in the center, at the center, and say, how is the fetus? And you understand, and I understand the fetal response to stress, we can significantly reduce the HI rate. And this is Lewisham. They got an award from the Each Baby Counts, and that is because 33% reduction in NU admissions. And this is Susanna Pereira is leading the change in Kingston, and they got a national award because there was a 60% reduction in HI rate. And this is another hospital in Wales. After they introduced physiological interpretation of CTG, you can see the total emergency section rate for fetal compromise went from 35% to 17%. And also the rate of HI also reduced, and they stopped cutting the skin altogether, because once you understand fetal physiology, no obstetrician would want to cut a poor baby's skin to find out whether the baby's brain is acidotic. And this is Lister Hospital. Once they had about 12 to 13 cases of HIE every year. And then once they made a switch to stop using NICE guidelines and went to physiological interpretation of CTG in January 2020, you can see within months, you see the change. And that is all because there is Jazz there, Labor Ward Leach is driving the change with a group of midwives and doctors. So all you need is a local team of obstetricians and midwives who really feel that they should reduce hypoxic injuries by using the right tool. What about outside the UK? This is Limerick in Ireland. They used to have 8 to 12 cases of HIE every year. And after the introduction of physiology, is only 2 cases. And they have one of the best perinatal outcomes in Ireland, Republic of Ireland at the moment. And this is Oman. You can see the emergency cesarean section rate is halved, and there's a 60% reduction in HIE. What about 2021, after Brexit, after the Irish border, after changes in the transport? Does it change? Does human physiology change after Brexit? And this is where I'm working at the moment, Basildon University Hospital. Unfortunately, the CQC visited there because there were 6 babies being brain cooled for severe hypoxic injury in 2 months in March, April 2020. But I told the midwives and doctors in Basildon that they are very good people. It's not their problem. The problem was this tool that they were using. They were using the NICE guideline sticker. And if you think about this, none of these numbers are based on any scientific evidence. And this number would be causing unnecessary harm to babies with poor reserves, like growth restriction or chorioamnionitis. And once they discontinued NICE guidelines and introduced physiological CTG guidelines, which was, as I said, um, developed by 34 CTG experts from 14 countries, and use these tools to identify babies who come with pre-existing injury and ask this question, how is this fetus all the time, putting the baby at the center of fetal monitoring. I think in the UK, we have forgotten that. We have put a sticker at the center of the baby fetal monitoring. We need to put the baby back. Fetal monitoring is about the fetus. It's about the baby's responses. It's about baby's individual reserves. So when we ask the question to midwives and doctors now, how do you feel the new change? Over 80% said they feel that the new physiological guidelines were very easy to use. 95.8% of midwives and doctors said it helps in individualization of care. But this is what is most important about outcomes. You could see in the whole of 2020, there were 11 babies who went out for cooling. But after the staff were trained on fetal physiology for the last 10 months, touch wood, not a single baby who had cooling due to intrapartum hypoxic injury or CTG misinterpretation. And again, when we started training staff on features of neuroinflammation, which NICE guidelines do not talk about it, there you can see there's a significant change in the number of babies with meconium aspiration syndrome. If you get chorioamnionitis management right, then by understanding and acting on chorioamnionitis based on the CTG features not mentioned in NICE guidelines, then you can see a significant reduction in the number of cases of meconium aspiration syndrome. And we had one case which was due to postnatal aspiration in a baby who was born with very good condition at birth, which we couldn't prevent it, which is very sad. But our aim is always zero. We want to have zero HIE, zero meconium aspiration in the labor wards where we work. And this is Basildon Sister Hospital, Broomfield, part of MSC, Mid and South Essex NHS Foundation Trust, with almost 12,500 births between three hospitals. You could see here, this is the HI rate, and this is the babies who were brain cooled in 2017. And once physiological interpretation CTG masterclass was carried out. And it's not only that, we need local champions. We have Kat Reeves, who is a fetal surveillance midwife there, who doesn't teach staff on NICE guideline sticker. No, she trains local staff on physiological responses of the human fetus, on the different types of hypoxia, and about chorioamnionitis. And you can see what a big difference such an MDT engagement and local leadership can make when physiology is implemented in daily life. So you can see whenever CTG masterclasses are conducted, when you give one CTG trace to the delegates who use NICE guidelines in their daily practice, you invariably get three answers. And 56% they say suspicious because they really don't know what's happening. And that's why obstetricians and midwives have that classification suspicious. We really don't know, it's suspicious. But once you train them, 93% of the delegates were able to identify what the problem based on their knowledge of physiology. And that's what physiology does. And 33% had pathological CTG, means they would have done some intervention. You can see the change once you change the mindset with physiology. This is Southend Hospital. Again, three answers at the beginning when they use NICE guidelines. And then some hospitals are excellent. They completely change. And this is Scotland again for the second time in a different group. You can see three answers, and 45%, they don't know what they're doing because it's not their fault, it's the sticker's fault, suspicious. But once they are trained, over 95% give you one answer, which is the correct answer. So this guideline, the problem is none of these numbers are based on scientific evidence. They are all felt by 5 obstetricians with the larger guideline group. But there were only 5 obstetricians who had expertise in CTG. But none of those numbers are based on any scientific evidence, and we also increased the number of the heart rate to 180. So let me finish by asking a question to us. For those of us who still continue to use NICE, non-evidence-based, personal opinion-based CTG guidelines, as I have said, I use several NICE guidelines in my clinical practice because the vast majority of NICE guidelines are not based on personal opinion. They are based on scientific evidence. They are based on grade A evidence, and their evidence statements reflect that. But unfortunately, as far as the CTG NICE guideline are concerned, and it has been clearly stated by the guideline group that they are all felt. There's no evidence. So our question is, would we accept if this same tool is used in not any other woman and the baby in the community, but on our sisters, on our partners, on ourselves. If I go through that, or our close friends, that's the question we need to answer, because this is sad and unacceptable that we are using a tool and the hospitals are getting into trouble, and the midwives and doctors in those hospitals, they are very good clinicians, they are very good people, but if you give them a bad tool, and that's what makes them have make them make mistakes, and sadly patients, both babies and families and women are paying for our mistakes. And it's not only the mistakes in terms of clinical outcomes and the human costs, it is also financial costs that the NHS has to pay when we use a tool which is not fit for purpose. So these are not numbers, they are humans. Babies are human, and they are the ones who are going to end up in the wheelchair if we are not doing the right thing. And we cannot be publishing reports year after year saying that we have a problem, and 72% of those babies, different care would have resulted in different outcomes if we are not willing to change the tool. The tool is the problem. It's not the midwives who are a problem. It's not the obstetricians who are a problem. And I'm very happy because when I started this journey, St. George's was the only hospital 10 years ago who did not follow NICE guidelines. And I was looked at as a crazy Sri Lankan looking different and trying to do something different. But now those red blobs are the NICE guideline units. And you can see in the UK how the journey has started. And the black ones, we haven't got any responses so far, and this is the available evidence or the information so far. But you can see that on the ground, midwives and doctors are waking up. They see the problem and they are changing. And those who are worried about medical legal stuff, and some senior obstetricians and midwives will scare you saying that medical legally, where do we stand? Well, medical legally, we use Bolam test, and Bolam test is what you do should be supported by a responsible group of midwives and doctors doing the same thing. And now you can see NICE guidelines is no longer the standard of care, because you can see the variation in the UK. There's going to be responsible body of obstetricians practicing physiological interpretation of CTG, and that is your Bolam test. In fact, in the guideline, there are 34 experts from 14 countries, including several from the UK. And therefore, medical legally, please don't worry that shifting from NICE to physiology will cause you any medical legal pitfalls, because medical legally you're judged based on what you do. Is it supported by a responsible body of medical obstetricians and midwives practicing in your field? And this particular information shows you that lots of units have moved from NICE guidelines. And in fact, if you look at the NICE guideline itself in 2017, they have made this very important um, statement in their front page. They have said it's your responsibility and it is not mandatory to apply the recommendations. So NICE itself is saying, because I think even NICE guideline group knows the amount of harm that is being caused by that guideline tool. And probably to protect themselves, they have said this, but this is your tool for your medical legal protection. It is not mandatory to apply these recommendations. So please don't worry about having medical legal issues. And it's very sad that the hospitals have been asked to pay the money back. And that's not the staff's problem, it is a tool problem. And that's why we need to change. So where do we go from here? We have two options. One is easy. Keep doing the same. So continue using NICE guidelines. Yes, babies are going to get damaged. They are going to die, and we know why. And that's because the tool is wrong and the tool is not evidence-based. But this is an easy option. And I'm sure humans, some of us would want to do that because it's easy. But then the difficult option is take a step back and ask ourselves, is it right for women to have unnecessary cesarean sections because of pathological CTGs without determining fetal response to stress? Is it right for babies to end up on wheelchairs because we cannot question a tool which is not scientific? And if you look at what we have been counting, in 2017, before the NICE guideline was revised, 951 babies were either brain damage or they died due to intrapartum related hypoxia. And again, you can see about 651 babies had, 65 babies had severe brain damage. We introduced this tool in the UK by some hospitals in 2017, and each baby counts. This is objective. This is from each baby counts. And you can see how much the total number of deaths and severe brain injury has gone. And you can see how many extra babies have had severe brain injury uh, once the tool was introduced. And the question is it fair on women, babies, our staff, because some of our staff get upset, they leave the profession, and the UK taxpayer is funding the £5 million we are paying every day to a lawyer because of our mistakes. 1.9 billion or 1,900 million pounds a year. And is it ethical? So let's take a step back. Normal, suspicious, pathological. If you look at each baby counts report, the last 5 of them, over 70% are due to substandard care. In other words, a different care may have given rise to different outcome. So as humans, whether you're a baby, a fetus, or an adult, we are exposed to stress. And most of us compensate to the stress. And then we go into decompensation. And once we start decompensating, we go into neurological damage, multi-organ failure, or death. So the idea is in labor to intervene at the right time. If we intervene based on pathological CTGs and decelerations, the poor woman is going to have unnecessary cesarean sections, and they might die of accreta, increta, percreta next time. If you intervene too late, having arbitrarily cutoffs of 30%, 50%, 90 minutes, 30 minutes, we will end up having neurological injury. Or if you artificially change the baseline heart rate from 160 to 180, those babies with chorioamnionitis or go through growth restriction who cannot go beyond 180 will be missed, and they may die or have severe damage. So the conclusion is it's the responsibility of each and every obstetrician, you and I, to practice evidence-based medicine. I never tell anyone to stop using NICE guidelines. That's not my role. My role is to give information for a good midwife and a good doctor to think and decide what is the best thing to do for our patients. Because at the end of the day, it is our responsibility to do first, do no harm. And it's up to each and every one of us to determine whether what we are using currently, is it fit for purpose? And ask ourselves how many more reports we need before we change. And I want to finish with something positive. And this is latest from Peterborough. You can see they had 10 to 12 cases of HIE. And after the masterclass, for the last 18 months, it's 0. And the amount of babies who unfortunately had a scalp cut, about 15% of 5,000 births, is now 0. And that tells you that knowledge improves practice, and practice improves outcomes. So let's work together and try to make HIE due to CTG misinterpretation and intrapartum hypoxic insults to 0. Let's not accept any other number than 0 for that. At the same time, let's stop historical nonsensical practices like fetal blood sampling, thinking that taking a sample from the skin reflects the brain because the scalp is close to the brain. That was 1962. Because when we do crazy procedures like that, it doubles the risk of cesarean section in women because we are cutting a non-essential tissue, which is acidotic in labor. And they might end up with accreta, increta, percreta next time or uterine rupture. So I'd like to thank you very much for listening to this short presentation. The aim is to help maternity units who are now trying to move away from pattern-based NICE guidelines to physiological interpretation of CTG by asking the question, how is this fetus? So I think it is our responsibility to convince the trust boards and the senior management by highlighting to them that the current tool, whereas NICE has produced lots of excellent guidelines which you should be using in the daily practice if they are evidence-based, this particular tool, CTG guideline produced by NICE, as stated in the guideline itself, is not based on evidence. And if we have to improve outcomes, then we need to do something different because we cannot allow babies and women to be damaged by these guidelines. Thank you very much.